Okay, good morning. Uh, we will chat today again about heart disease. I want to kind of stick with the same topic again because I just think there's a lot of information here, and I want to make sure that I'm presenting things in a format with which it's understandable to everybody. And so, revisiting a bit more what is the risk of heart disease? Uh, Objectives, identify what are risks for heart disease, models and tools used to predict who should be screened, labs, imaging, and ways to modify that risk and how we look at it primary versus secondary risk screening. So main risk factors, clearly age, that's difficult to modify. Gender is quite difficult to modify, as is our ethnic background. But there are definitely risk factors that get taken into account with when we're thinking about heart disease and elevated cholesterol, all of those things. Um, Hypertension and smoking, those are the two biggest modifiable lifestyle risk factors that we're dealing with. Diabetes, high cholesterol, uh, family history of early or premature heart disease. So that's less than 55 for men and less than 65 for women. Chronic kidney disease is an issue, as you can imagine, as is obesity. Additional risk factors, uh, metabolic syndrome. So metabolic syndrome, you can see is an increased waist circumference, elevated triglycerides, uh, elevated blood pressure, elevated glucose, low HDL. Any three of those will make a diagnosis of metabolic syndrome. Certainly, we worry about chronic inflammatory conditions, so rheumatoid arthritis. Certainly, the other example that's shown here by the American College of Cardiology would be HIV, and that clearly is would be a risk factor. But also things we don't think about, premature menopause can be a risk factor, and also those pregnancy associated conditions if people have had preeclampsia or high blood pressure associated with pregnancy. A couple other biomarkers, which we talked about last week, would be that elevated C-reactive protein, an elevated lipoprotein A, that's that little inherited cardiac marker, and also an elevated ApoB is also an independent risk factor, which we talked about. There's another test called an angle brachial index, and that is a risk factor, and that's one that I would say is not tested as often, but that is something to be thinking about. Uh, I got these from Dr. Mark Wade. He is a cardiologist, I believe, and has a lot of information on his website, and I've got it linked in the references. Lots of different information about things to look at, and so basically talks about again all these, what are these risk factors that we're thinking about when we're thinking about coronary risk, and what's not noted in the initial ones, in which I had taken from a common reference called Up to Date, you know, there's socioeconomic factors that go into it. There's also geographic factors, psychosocial stress, physical activity, and so we can add these different things up. Like, do you have other heart disease or heart arrhythmias? Do you have sleep apnea? Are there psychiatric disorders? And we'll look at a couple different systems here, but primary prevention really means you've not had a heart issue, you don't have a diagnosis that is equating to heart disease right now or stroke. So primary prevention is where most of us fall. If you have had a heart attack, a stroke, if you have a diabetes, which is considered a heart disease equivalent, now we're talking about secondary prevention. So we're trying to prevent any secondary problems. And you can see, like, when we really look at, and I'll show you another risk tool we can use. There's lots of them. If you have little to no risk factors, and you're especially looking at different levels of LDL, certainly at 55, boy, if you have a LDL of 55, you can have a whole bunch of risk factors, and we're still looking at lifestyle modification. If you're getting up to 70, or if you're less than 100 or 116, and then there's a big jump between 116 and 190. But you can see a lot of things right here, like most of this and every one of these, if you look, lifestyle intervention is number one. But this just gives you kind of an idea of like, how do we stratify this, and how do we think about it as to like, what should we be doing? Are there people that need to be put on medications right away? So this I find is a good tool and a good reference, this website. The other tools that we use to predict, we use a Framingham risk score. There's a Reynolds score, and that's a separate one for men and women. The American College of Cardiology and American Heart Association, they're behind this ASCVD risk estimator. And when we think about these, we got to think about the population that gets studied to develop these tools. There's tools that have come out of China. We also, and other populations, Scandinavian populations, and, we all have different backgrounds and inherent risk there, and maybe even different dietary factors to be thinking about. But all of these tools clearly could over and underestimate risk. And as I talked about, there's a lack of socioeconomic or geographic factors, and that's kind of what I liked about the diagrams that I shared with you from Mark Wade's website. And then different outcomes are measured for a lot of these things. A lot of them have your 10-year risk, and others will have your 30-year or 30-year risk or a lifetime risk. And I will show you one. I got to pull up on see if we can. I'm going to go to this. So this is interesting. So just for fun, this is the website. So it's a atherosclerotic coronary vascular disease risk estimator. And if we plug in my data, and this isn't my best data that I've had in years past, but it's where we are right now. So put in my blood pressure, that's been good. I'm a female and I'm white. You can see it accounts for a little bit here. My last total cholesterol was 236. My HDL was 91, and my LDL was 134. I don't have a history of diabetes. I am not a smoker. I'm not on aspirin. I'm not on a statin. I am not on hypertension, and I don't need to refine a current risk estimate. So we can see right there, my 10-year risk is 0.8%. So it's really low, right? Interesting. I like my lifetime risk is 39%. So that's pretty interesting. The cool thing when you go through a site like this, we can do different things, determine, therapy. I haven't done any treatments. So if I said I was going to start a statin, I don't think it's going to show that because I don't qualify. But if we did start a medication for somebody, we could actually see what would be the percent risk reduction. But right now, and anybody can go to a website like this and see this. And this is just one of many tools. And I thought it would be fun to show you a little bit. There, U.S. Preventative Task Force has tools. There's lots of tools out there. So when I work with people, these are kind of things that are going on in the, in my mental machinery while we're talking and before I see you and I look at lab results. So these are the kind of things that I'm thinking about. So to see, sweet, we got right back to where we were. So I just feel like that's a super, it's just super helpful tools here that we can use, and I just wanted to share those with you. And so I actually was talking to a parent with some young kids just earlier this week, and when do we start screening? And actually, interesting, even the American College of Cardiology suggests starting at age 20. Certainly younger if risk factors are present. There are guidelines that even suggest if we have a child with diabetes or a child that would be obese, like there are guidelines to even put children on medications. And so I think, you know, I think starting there's definitely an age cutoff somewhere, but depending on risk factors, but probably starting at age 20 to have your cholesterol is probably not a bad idea. The intervals that are based on that are guidelines right now and based on risk, they're pretty interesting. If you're a low risk, it recommends every 4 to 6 years, more frequently with higher risk or optimization. And I would say in practice, generally this is done yearly. People get their cholesterol checked, and I'll talk about the other biomarkers. And and I would argue, certainly we're trying to optimize health. So we got to think about those endpoints. So if your endpoint is to avoid death, well, maybe we only need to screen you once in a while. If your endpoint is, I want to be really healthy and I want to be able to continue to hike, I want to be able to continue these things. Well, there's a different level between I don't want to be dead and I do want to do all these other things. So I would argue that it does need to be done more frequently, certainly more frequently than every 4 to 6 years. And certainly if I'm working with somebody, we may recheck things in a month or 3 months to see if we are moving that needle. And I would just say, it's hard to change what we don't track. So that's why I think it's so important for us to track these things. And so what sort of screening tests? In a lot of these we are doing, and you have probably had these done at some point. So our biometrics, we need height, weight, body mass index. We can do body compositions as well, which is actually more accurate, and blood pressure. Lipid panels, and I talked about a little bit a couple weeks ago about ApoB, or the NMR, which is an advanced lipid profile. And an argument for the ApoB is that the testing is similar lab to lab, whereas NMR, there's several different versions of the test. So you could theoretically get one number from one lab and another number from a different lab. So that's a little bit harder to match up. Lipoprotein A, the LP little a, that's something that needs to be done at least once. So, and interestingly, the 2019 European guidelines, they really actually recommend ApoB for anybody with diabetes, obesity, elevated triglycerides, or that metabolic syndrome that we talked about. And basically they say, if it's available, do an ApoB. So that's something that we're doing more regularly now. And I think that gives us a better marker to go by. And just to remind everybody that ApoB encompasses more of those lipid particles that we know are atherogenic. So probably just a better overall marker. A urinalysis is important, and a complete metabolic panel, really looking for evidence of early kidney disease. Complete blood count, vitamin D, a C-reactive protein, that's a non-specific indicator of inflammation. That's really important when we talk about that endothelial lining of our vessels. And if we have inflammation, that's when we can have damage there. Hemoglobin A1C for diabetes risk. Also really important to be screening for thyroid, because untreated thyroid or underactive thyroid will actually cause lipid abnormalities as well, and elevated cholesterol. Other things to consider case by case would be uric acid, homocysteine, which is a marker for B12, and fasting insulin. And we're doing many of these tests, if not almost all of these tests. And different imaging that can be helpful when we're thinking about risk assessment. Many people have had an EKG. That's where you have the little stickers on your chest, and that's really looking at your heart rate and rhythm, and we can learn things from that. Chest X-ray can be helpful. We can see if your heart looks like, do your lungs look normal? An echocardiogram is an ultrasound of your heart. That's a great non-invasive way to be able to look at your heart function. Certainly stress tests. So stress tests is when we run somebody on a treadmill, or if somebody can't run on a treadmill, we can do basically what we'd call a drug study, and that's where we give you medication which stresses your heart. And that can be combined with that echocardiogram or with nuclear imaging as well. Other tests that we can use to get an idea of vascular dysfunction and early heart disease is something like a CIMT, which is the carotid intimal medial thickness, and that's where we look at the carotid artery and look at the thickness of a portion of that vessel wall. Coronary artery calcium scores. This is actually a pretty quick low dose CT where they actually look for calcium in your coronary arteries. I've used this a few times when I've had, I would say younger folks, 40s, 50s, younger, that have real high cholesterol, but seem to me to be really fit, not overweight, good diet, you know, more some of these like an elevated LP little a, so they have these familial risk, and oftentimes we'll do a coronary artery calcium score then, and if it's normal, then we, you know, that's just reassuring that we're, you know, staying on the right track. Whereas if I had somebody that was seemingly healthy, had an elevated coronary calcium score, it might push me to say, wow, well, maybe even though things look good, maybe we should put you on a statin or another medication to help reduce risk. We can do coronary CTs, cardiac MRIs, angiography. That's when they actually go in to your vessel, usually through your groin, sometimes through your arm now, but they can actually then look at your valves and use dye to do all kinds of imaging. And there's another test that I'm not sure that anybody is doing locally, and that we can look at endothelial function, and that there's some evidence that that is actually helpful and potentially predictive, and just not widespread used yet. So that might be something we see more on the horizon. So when we talk about modifying risk, and we talked about this previously, but we're thinking about primary and secondary prevention, and I'll run through a chart on each of those. But diet, Mediterranean diet, it's the one with the most data. There's lots of books. One of my favorite is the Mediterranean Method by Stephen Masley. Well-written book, and it's a cookbook as well, but super informative. In terms of lifestyle, 30 to 60 minutes of aerobic activity daily, strength 2 to 3 times a week. And I'll, right toward the end of the talk, I'm going to present some data that I just learned last weekend when I was attending a conference virtually. Medications, statins, there's fibrates that we use, especially if we're dealing with higher triglycerides. PCSK9 inhibitors, those are for, they're used in high-risk situations, super expensive right now, and not widely available. Niacin is something that's been older that we've used for a long time, and the biggest thing we got to watch with that is risk for like liver disease. And supplements, the thing with the biggest, data supporting it is omega-3 fatty acids, and you're really looking at 2 to 4 grams a day. I know Tom Dayspring would say 4 grams of omega-3s each day, and so you need a fair bit of fat of omega-3s. But we here have salmon that we can be eating that's generally pretty clean, so that is a good option as well. So looking at this primary prevention, this came from the American College of Cardiology. So when we think about, this is a neat chart. So primary prevention, remember, you don't have disease. And, we look at different ages, lifestyle age, 0 to 19, 20 to 39, estimating that lifetime risk, kind of like that calculator that I showed you. And then 40 to 75, if we have somebody, now we're talking about elevated LDL levels, and then that 10-year risk. And then as we go down, we can break things down. Everything is about lifestyle modification, and I'll show some support for that as well. This is kind of neat because it really, this breaks it down similar to the other graph that I showed you. It's just a different arrangement, and it really talks about some of those risk enhancers or additional risk factors again. And then for secondary prevention, so this is somebody that's had clinical disease, clearly foundationally a healthy lifestyle is really important. Um, and then are you at really high risk or very high risk? Age, do we have the goal is actually once if somebody has a heart attack or stroke, we will look at an LDL, and the goal is actually not necessarily we want it below 70, we want it below whatever. It's really shooting for a reduction of 50%. And so that kind of breaks it down this way. Age greater than 75, these are different things, and it's kind of like screening for many other things. If you're 80 years old and you're really healthy, like, yeah, we should be screening for things. If you're 80 years old and you have heart disease, lung disease, and you are, pulling your oxygen tank behind you, um, then you start to, you have to weigh just the variables of does it make sense to do a bunch of screening right now, or do we just treat? Um, so these are pretty helpful, and they're not here for you to memorize anything, or I don't actually expect you to like understand this, but I just want to show you how it is that we risk stratify some of these things. And then this is the something that was really exciting that I just learned. So there was a study published in the recent Nature Medicine journal, and it was published on August 17th. There were 96,476 participants. So this links volume and intensity of physical activity to mortality, to death. So of these participants, mean age was 62, 56% females. So this was all done in Britain. So this baseline or reference group expended less than 200 calories a day of extra beyond their basal metabolic rate, so with activity. If you actually expend 337 calories of extra energy expenditure, there's a 31% lowered incidence of cardiovascular mortality. If you're expending 500 extra calories a day, 54% reduction. And 670 calories a day, 78% reduction. And that's crazy. None of the medications, if we were to go back, like doing these LDL, like statins, doing PCSK9 inhibitors, none of those would touch this incidence of cardiovascular mortality. And so I think that that's really cool. And it's cool that there was a study, and then they talked about wearables. And then I wanted to show you, I'm going to escape again. I pulled up, this is basically, I know I talked to a lot of you, and I've mentioned it before. I wear a little ring called the Aura ring. And so I was able to actually, this is my data, and this is my data today, right now. So this tracks basically readiness, and I can show you how this gets broken down. What was my resting heart rate? What was my heart rate variability overnight? My temperature, my recovery index, my previous night, like my sleep. This is 0 to 100. My sleep generally is in the 90s. This was kind of a bad night of sleep for me. My sleep balance has been okay. You can look on average. My previous day activity was good, activity balance. And so I can follow all of these different metrics. And the cool thing so I'll show you this sleep thing. This is kind of cool. This was last night, and you can see in here, like, here's where I'm awake. This is REM sleep. I had some REM sleep and a lot of light sleep and deep sleep. And that's pretty, to me, this is all really fun stuff to look at. But if we go back, say, this is probably more typical for me, 7 hours and 25 minutes of sleep. And you can see it's really common for most of us to have deep sleep early in the night. And then light sleep is intermittently going to show up, and we tend to have more REM sleep. And that would be more where you're dreaming and that kind of stuff later in the morning. But when we look at activity, so yesterday, like I only walked to work and back, so I didn't really do much for my cardiovascular mortality yesterday. A couple days ago, like I went for a run, so it had set me at 250 calories, so that's that baseline group that would have been in the study. And you can just see, like, on different days when I've had more activity, and depending how much activity you have, how much recovery it has, it gives you an idea. Like after a big day, I mountain biked this day. The next day, you can see that it says, hey, back off a little bit. And so some of the metrics and the data that we can get on these things are so, so cool. And like this, a lot of you have seen me over the years. I always have like one of my Garmin, like a running watch on or something, and it tracks a lot of this, but I found this Aura ring to be, it's a little bit more fun for me, and it's a little bit geeky in data, but it really triggers you. Are you moving every hour? Am I meeting my daily targets? And how's my training frequency and volume? And am I getting enough recovery time? And what's my overall activity score? And so the cool thing here is this, they published this linking volume and intensity of physical activity to mortality, but they also uh, there was a study published based on the same participants about wearables, and wearables being a watch, a ring, a Fitbit, those kind of things. And so I thought that this was really cool to share with people, because it just shows um, how important movement is for all of us. And so, as you know, that makes me really excited when we can do things under our own power to mitigate risk. And so references, lots of different references here, up to date. That's something that as patients you can access. And there's a whole patient data bank. As a physician, I pay for the access. Peter Attia, who I've talked about before, this is that Tom Wade, his website, which have found real helpful, and some good information. And then guidelines. Hold on, I hit my scrolly. Guidelines for the management of dyslipidemia through the European Heart Journal, um, guidelines from American College of Cardiology, uh, and then role of cardiac imaging in clinical practice, and then a little link and hyperlink to endothelial function as a marker of preclinical atherosclerosis. That's actually an Italian study, and I can't read Italian, so it didn't do me any good to download the study. I could read the abstract that had been translated in English. So, and then these last two studies are this wearable device measured physical activity and future health risk, and linking the volume of intensity of physical activity to mortality, which is really cool. And with that, that's good. And this is the gang out hiking last week, which we try to do every Thursday.